Welcome to the video answers for Part 1 question set number 4. Now you've already downloaded the PDF and answered those questions, right? Don't skip that step. All right, let's get going. First question, homocystinuria is one of the few diseases that can result in subluxation of the lens. What are the different causes of homocystinuria? So there are 3 different ways you can get homocystinuria, 3 different kinds of enzyme defects. But before we list those, let's review the pathway that we're talking about. So you start with homocysteine, and you can do one of 2 things with it. You can either combine it with serine to make cystathionine, and the enzyme that catalyzes this step is cystathionine synthase. And then B6, vitamin B6 is a cofactor at this step. And then from there, you can convert that cystathionine to the amino acid cysteine. Then the second thing you can do with homocysteine is to convert it to methionine, and the enzyme here is homocysteine methyltransferase. And this enzyme requires vitamin B12 as a cofactor. So this is why we sometimes treat patients with high homocysteine levels with vitamin B12 to make sure they have enough of that cofactor to convert homocysteine to methionine, because high levels of homocysteine are associated with atherosclerosis and heart disease. So you can guess that if you're deficient in either of those 2 enzymes, you're going to get hyperhomocysteinemia. And that's going to build up and spill into the urine, and that's homocystinuria. So you can have an inherited deficiency of homocysteine methyltransferase, or you can have a deficiency of cystathionine synthase, or the third defect is where you have cystathionine synthase, but the enzyme has a low affinity for that vitamin B6 cofactor. So the enzyme's there, but it won't bind to the cofactor, so it doesn't work as efficiently. Then the second part of the question asks, how does the treatment differ for each of these? Well, for all of these, you're going to need to supplement cysteine, because if you can't make cysteine, cysteine becomes an essential amino acid. Then, if you have a cystathionine synthase deficiency, you also want to reduce dietary methionine, so you're not making so much homocysteine. And you want to increase vitamin B12 and folate to help shunt that homocysteine back toward methionine so it doesn't build up. And if you have that mutated cystathionine synthase with that reduced affinity for vitamin B6, you're also going to give extra vitamin B6. And then one more thing to remember here is that Marfan syndrome also presents with subluxation of the lens. So on your test, they may throw that at you to confuse you, since they both present in a similar manner. You know, patient with tall stature and long fingers and subluxation of the lens. So be sure to be able to identify the differences between homocystinuria and Marfan syndrome. Next, diagram the pathway by which the cochlea communicates a signal to the primary auditory cortex. Basically, the signal goes from the cell bodies of the spiral ganglion, which is found in the cochlea, to the cochlear nuclei, then to the contralateral superior olivary nucleus, then to the lateral lemniscus, then to the inferior colliculus, then to the medial geniculate body, and then finally to the primary auditory cortex. Next, a 20-year-old Italian woman complains of weakness and fatigue. CBC reveals microcytic hypochromic anemia with a normal iron panel. What type of thalassemia does this patient most likely have? Well, the clue here is that this patient is Italian. Don't just memorize that. It could be a patient presenting with the same clinical scenario from any Mediterranean country, Greece, Spain, and so on. Both alpha thalassemia and beta thalassemia both cause microcytic anemia, but alpha thalassemia is mainly seen in African and Asian populations, and beta thalassemia is mainly seen in those Mediterranean populations. So beta thalassemia patients have a mutation in the gene for the beta globin chain of their hemoglobin, so they're not making as much hemoglobin, and that's why they become anemic. Now, next part of the question is, what's the structure of hemoglobin H? So normal adult hemoglobin, which is hemoglobin A, is made of 2 alpha globin chains and 2 beta globin chains. We just say that in beta thalassemia, there's a defect in the beta globin. In alpha thalassemia, there's a defect in the alpha globin gene. So if you have a severe form of alpha thalassemia, you're hardly making any alpha globin, but you have lots of those beta globins around. They have no dance partners, so the beta globins start to pair up with each other. So instead of 2 alpha globins and 2 beta globins, hemoglobin H is made up of 4 beta globins. Next part of the question is, what disease results in hemoglobin H production? So we just said it's alpha thalassemia, but there are several different flavors of alpha thalassemia. Normally you get 2 alpha globin genes from your mom and 2 alpha globin genes from your dad. You can have mutations or deletions on 1, 2, 3, or 4 of those alleles. Now, the one where you have hemoglobin H production is where you have 3 defective alpha globin alleles. So these patients do make a little bit of alpha globin, so they can make a little bit of hemoglobin A, but not much. Most of what they're making is hemoglobin H. And then what's the structure of hemoglobin Bartz? So hemoglobin Bartz is a type of abnormal hemoglobin that's made of 4 gamma globin molecules. And what disease results in hemoglobin Bart's production? Well, the answer is alpha thalassemia again, but let me explain. Normally, fetuses use primarily hemoglobin F, which is fetal hemoglobin. And that's going to be 2 alpha chains and then 2 gamma chains. But if you have the most severe form of alpha thalassemia where all 4 of those alpha globin genes are deleted, you're not going to make any alpha globin, so that fetus can't make hemoglobin F. So they're going to make hemoglobin Bart's instead. All those gamma chains start to pair up together, and that's hemoglobin Bart's. The Bart's name comes from the fact that it was discovered at St. Bartholomew's Hospital in London, which is called St. Bart's. I like to think about Bart Simpson being a little kid, so this is a disease seen in infants. The clinical result is that these fetuses don't have hemoglobin F to carry oxygen, so they have very poor oxygen delivery in utero, and they develop something called hydrops fetalis, which is fetal edema and ascites and so on. So this most severe form of alpha thalassemia is incompatible with life, and these pregnancies usually end up in spontaneous abortion. Next, a 34-year-old obese white woman develops urinary retention after undergoing a laparoscopic cholecystectomy. Which cholinergic agonist can be used to treat post-op ileus and urinary retention? So you can use either a direct cholinergic agonist, like bethanechol, or sometimes we'll use a so-called indirect agonist, like neostigmine, which really isn't acting as a cholinergic receptor at all. It's actually a cholinesterase inhibitor that increases the amount of acetylcholine found at the synaptic cleft. So it has the same end result of increasing cholinergic transmission. So again, we call these indirect cholinergic agonists. And then, what conditions can be made worse by using cholinomimetic agents? So cholinomimetics can cause bronchoconstriction, so they might make asthma or COPD worse. And then acetylcholine also stimulates stomach acid secretion, so they might exacerbate peptic ulcers. Next, for what conditions is hyperbaric oxygen therapy particularly helpful? So we use hyperbaric oxygen for severe carbon monoxide poisoning, for decompression sickness and arterial gas emboli, and then maybe for gas gangrene caused by Clostridium perfringens, which is an anaerobe. And then there's also some theoretical use of hyperbaric oxygen in treating osteomyelitis and also in treating acute MIs, but that's certainly not standard therapy yet. Next, a 23-year-old man undergoes a splenectomy due to splenic rupture from blunt abdominal trauma. What would you expect to find on this patient's peripheral smear after the splenectomy? You're going to look for Howell-Jolly bodies, which are basophilic nuclear remnants seen inside some red blood cells. Now, normally those cells are going to be removed from circulation by the spleen, but if the spleen's gone, you're going to see those red blood cells with the Howell-Jolly bodies. And then asplenic patients are susceptible to which encapsulated organisms? So this includes Salmonella, Strep pneumoniae, Klebsiella pneumoniae, Haemophilus influenza type B, and also Neisseria meningitidis. And then what vaccines for these encapsulated organisms should be given to asplenic patients? You want to vaccinate against strep pneumo, H. flu type B, and Neisseria meningitidis. Next, if stroke volume determines cardiac output and contractility determines stroke volume, what determines contractility? So there are actually a lot of different factors that influence contractility. Contractility can be increased by catecholamines and also by sympathetic stimulation. You can also increase contractility by increasing intracellular calcium and also decreased extracellular sodium. And then finally, digoxin, which actually works by increasing intracellular calcium. And then contractility can be decreased by beta-1 blockade, heart failure, acidosis, hypoxia, the calcium channel blockers verapamil and diltiazem, decreased intracellular calcium, and increased extracellular sodium. Next, what's the pressure in the potential spaces of the body, including the pleural cavity, the joint spaces, and the pericardial cavity? So the hydrostatic pressure in these spaces is actually negative, which is going to facilitate the diffusion of fluid into these spaces. The interstitial fluid hydrostatic pressure of the pleural cavity is normally -7 to -8 centimeters of water. The pressure in the joint spaces is -3 to -5 centimeters of water, and the pressure in the pericardial cavity is -5 to -6 millimeters mercury. Next, how does standard deviation differ from the standard error of the mean? So what has 2 thumbs and loves statistics? Not this guy, probably not you either. But unfortunately, this stuff is very high yield for USMLE Step 1 and COMLEX Level 1. So let's go ahead and go through it. Standard deviation is a measure of how much variation there is between data points in a sample. So there's the mean, or the average, and then the actual data points are going to fall anywhere along that bell curve. Now, standard deviation is a number, and if you draw a vertical line through the x-axis at 1 standard deviation above the mean, then you draw a line at 1 standard deviation below the mean, about 68% of the data points would fall between those two lines. So the x-axis value where that holds true is the standard deviation. So one standard deviation above and one standard deviation below the mean is going to contain 68% of the values. And then two standard deviations will contain about 95% of the values. And three standard deviations will contain about 99.7% of the values. Now, the good news is you're not going to be asked to calculate standard deviations, but you definitely need to understand what they mean. Now, standard error of the mean is a measure of how well the mean of a particular sample is going to predict the mean of the entire population. Say you wanted to estimate the average height of an adult male in the U.S. You could measure every adult male and calculate the mean, but that's fairly involved. So instead, you could measure a sample. Say you measure 10 men and then calculate their average height. Well, that might come out pretty close to the actual average. But what if your 10 men all just happen to be NBA players? Well, the mean of that sample is going to be skewed, and it's not going to reflect the mean of the entire population, right? Well, the standard error of the mean is a measure of how far off you are from the actual mean of the entire population. The way it works is that the larger the sample size, the closer you get to the true mean of the entire population. And then the smaller the standard error of the mean is. The equation for calculating the standard error of the mean is the standard deviation divided by the square root of the sample size. So the larger the standard deviation, the larger the standard error of the mean. And the larger the sample size, the smaller the standard error of the mean. So that's standard deviation and standard error of the mean. Then the second part of the question asks, which one is used in calculating confidence intervals? So confidence interval is a range of values on either side of the mean that estimates how confident you are that subsequent studies calculating the same average are going to fall within that range. And we calculate confidence intervals using the standard error of the mean, or SEM, which is the answer to the question. The confidence interval is the range from the mean minus z times SEM to the mean plus z times SEM. So SEM, again, is standard error of the mean. But what the heck is z? Well, z is a standard number used to calculate a specific confidence interval. So the z for a 95% confidence interval is 1.96. It's easier just to round this to 2. The z for calculating a 99% confidence interval is 2.58. Now, these z numbers are definitely worth memorizing for your test. And you can see that z gets larger as your confidence interval goes from 95 to 99%. This only makes sense because the only way to be more confident that a number is actually correct is to widen the range. So again, the more confident you want to be about your data, the bigger your confidence intervals need to be. So let's illustrate this with an example. If your study of 10 males determined that the average height for an adult male in the U.S. was 5'9" or 69 inches, now we want to calculate how confident we are that another study would produce the same results. We're going to be using a confidence interval. So if we did the math and we calculated that the 90% confidence interval was plus or minus 3 inches on either side of 69 inches, that would be, the range would be from 66 inches to 72 inches. So what does that mean? Well, how can you be certain that the 69-inch average height you calculated in your study is a reflection of the true average height for the larger population? Well, you can't be 100% certain, but you can have a certain amount of confidence that your study reflects reality. What that 90% confidence interval of 66 to 72 inches tells you is that you can be 90% confident that the true average height falls somewhere between 66 and 72 inches. All right, enough statistics. Let's do one last question. A 48-year-old man presents to your office with a persistent cough that's begun to become bloody. Chest x-ray reveals a coin lesion within the lung parenchyma. Further workup reveals that the patient has the most common type of lung cancer in non-smokers. So which cancer is this, and what other lung cancers are not associated with smoking? So the most common type of lung cancer in non-smokers is bronchial adenocarcinoma. Now, lots of smokers get adenocarcinoma too, but if you're a non-smoker who has the bad luck of getting lung cancer, it's most likely going to be adenocarcinoma. Then bronchoalveolar adenocarcinoma and mesothelioma are also not closely linked to smoking. Though technically mesothelioma is a pleural cancer, not a lung cancer per se. And then which lung cancers are associated with smoking and where are they located, centrally or peripherally? So the lung cancers that are most associated with smoking include small cell carcinoma and squamous cell carcinoma. I want you also to remember that small cell carcinoma and squamous cell carcinoma tend to be located centrally. So you've got the S for smoking, and you've got an S for small cell and for squamous cell, and then you have that S sound for central. All right, that'll do it for this question set. I'll see you next time.